My name's Steve Dietrich. I'm a respiratory therapist. I have the privilege to be a respiratory therapist for 36 years. And of that 36, I've known Keith for probably 20 plus years. When I lived in North Texas, we worked together, had a good time. But anyway, we're going to talk about reducing hospital readmissions and how you, the respiratory therapist, can have a positive impact. A lot of times people blow past respiratory therapy. They're like, okay, O2 boys and girls and neb jockeys, but I'm going to assure you, and you know this, we do so much to move the patient through the continuum of care, and we're going to circle back to making sure that as we do this, we're going to not have that patient show back up. And again, we'll talk about this a little bit more. So here we go. All right, objectives. What is pay for performance? That's how we get reimbursed. The admitted diagnosis, readmission timeline, the penalties that the hospital gets when the patient is readmitted, respiratory therapy, us, and then value-based care. And I want to circle back on that and have you think about what does that mean? Value-based care. Put it down, write it on a little notepad right now. What do you think that is? We're going to talk about it. So what is pay for performance? Pay for performance comprises a payment model that attaches financial incentives and penalties to provide a performance. I didn't realize this, but many years ago, when we went to the Affordable Care Act, President Obama initiated that, and I knew there were some changes in how hospitals dealt with things, but I didn't realize until I started digging down into this, what does that actually mean from an incentive and a penalty? Now, some hospitals are big. Let's say a 500 bed hospital, that's pretty good size. If you have patients that show back up, what is that penalty? And for those hospitals, it could be millions of dollars. For a 100-bed hospital, it could be hundreds of thousands of dollars. So again, we're going to talk a little bit more about that, but think about the financial impact that you, the respiratory therapist, can have in a positive way. All right, so here's the diagnoses that are under pay for performance: heart attack, heart failure, coronary bypass surgery, then we get hip knee replacement, pneumonia, and COPD. And we're going to focus on the last two, primarily the last one, COPD. That's in our wheelhouse. We get that. So what's the timeline? 30 days from the date of original discharge. So you have your patient shows up in the ER, you walk them through the continuum of care, and they're discharged on the 15th of the month. 30 days from there is where we're going to look, not having that patient come back. Now, how many of you have had patients that that you see and you walk them through the continuum of care and you discharge them only to have that patient show back up next week or the week after? When they do, that's where we get a penalty. Whether, again, they come from you or they come back to your hospital or they go across town, you get the penalty. You get the penalty. Yeah, frequent flyers. Here's the penalties: up to 3% of the revenue you get from CMS. All right, so if you are like most everybody else, your hospital gets about 70% of their revenue from Medicare, Medicaid, 70% of your revenue. All right, now take that. Now, if you take 3% of that revenue you get from CMS, what is that dollar amount? Yeah, it's huge. It's huge. So we're going to look at DRG 190. Okay, COPD. And I got this information from CMS. So it's a capitated payment. Once you give them the DRG, it's capitated. So it's capitated at around $6,700. Now, there could be difference from the West Coast to the East Coast, North, South, but it's pretty close to that. That was the average that I got. So when that patient shows up, the hospital's going to get reimbursed $6,700. Now, think about this next one: the ICU bed cost. What does it cost you to have that patient in an ICU bed? and about $3,500 a day. Now that pays for respiratory therapy, OT, PT, dietary, pharmacology, radiology, nursing services, physician. That's expensive versus a ward bed at $1,500 a day. And then the average length of stay is 4.4 days. How many days does it take to consume that capitated payment? It's gone in just a couple of days, especially if you move them to ICU. Now you can add things onto that. If you intubate and put them on a vent, that changes the DRG and that. But again, I want you to think about this. We work with a capitated system. So again, no matter what you do, you're only going to get this much money. So again, it's our goal, our responsibility as providers at the bedside to do the very best we can every single day, take care of those patients that can't take care of themselves. All right, so the next one we have, next slide. Here's what it's telling us. All right, the average cost overall admission, 14,500. Average cost for a single hospital readmission. Here's your cost, $16,300. Now that was in 2020. And now it's a little higher than that, it's around 17,000. That's our cost. Not what you're billing for. That is your cost. And you're like, oh my gosh, it cost me that much? Yes. Healthcare is very expensive, and we need to be thinking about what we're doing as we navigate that patient through the continuum of care. So average cost, it used to be, and now here it is right now. All right, pay performance in healthcare, P4P, also known as value-based payment, comprises payment models that attach financial incentives and disincentives to provider performance. All right, here's the downside. If you have the patient that shows back up, you're going to get a penalty. So it's like, oh man. But if you're doing really good and you're moving that patient through the continuum and you don't have that, you're incentivized. You're going to get some money from the federal government that says, hey, listen, thank you very much. And here's a little financial incentive. And I thought that was really cool. We talk about negatives all the time. Here's the positive. We're going to get some money. Oh, it's a bonus. Great. So think about that. You have the ability to do that. So pay for performance is part of the overall national strategy to transition healthcare to value-based medicine. We're moving in that direction, and we're going to really drill down on value-based. I told you, circle that. While it still utilizes fee-for-service system, it nudges providers, you, me, toward value-based care because it ties reimbursement to the metric-driven outcomes, proven best practices, and patient satisfaction, thus aligning payment with value and quality. Now, again, when we're at the bedside, do you not every day try and do the very best you can for that individual patient? Now, I can tell you when I started a long time ago, when I was a student at the University of Texas Medical Branch in Galveston, students ended up doing floor care. And they would hand you a bunch of cards that had patients' names on there, and you went at it. And that was it. So in the morning, you get there at 6:30, 6:45, you're getting a report, and you get all these cards. You get a stack of like 35 or 40 patients. And these cards, you're like thinking, how am I going to get this done? So again, it wouldn't be unusual for me as a student to have 2 or 3 or 4 patients on nebulizer at the same time. I'd start patient in room 1, then go to room 2, room 3, room 4, then I'd circle back to 1, and I would do that. And I was like, okay, here's the volume I'm trying to get. As I matured and got better, that's not what we need to do. So again, we need to focus on the patient satisfaction, and not just throwing nebs. And again, that was mine. I did that. I own that. Pay for performance in healthcare programs, while private payers are also experimenting with deploying pay for performance. So that means insurance companies are looking at what Medicare, Medicaid has done and said, hey, maybe we need to change what we're doing. So again, it's coming. So again, spurred by the Affordable Care Act, is leading the way in value-based care with a variety of payment models, including several pay for performance systems. Again, it's coming. We're there. As largest funder of healthcare at almost 40% of overall spending, it's a little more than that. CMS has developed various pay for performance models, including 3 programs that impact hospital reimbursement through Medicare. We've talked about this again, circle it. Hospital value based purchasing program. So, what does that mean? So, I'm in materials management. I'm like, okay, what do I need to get? And that's why GPOs, group purchasing organizations, are so huge now. It used to be when I was a director of respiratory therapy, a salesperson could come in and say, hey, Steve, here's this new nebulizer and it does this, that. And I would say, well, yeah, that's pretty cool. And I would say, oh, yeah, that's great. And I could write out a request for that, turn it into materials, and they would buy that. Doesn't happen now. Now it says, well, are they on contract? And again, if you deal with that, you know what that GPO is. So you're like, well, is it Vizient? Is it HPG? Is it Premier? Who's my group purchasing organization? And they will tell you what you can get. So again, as a vendor, you want to make sure that you have those contracts with those GPOs. As a buyer, again, I assure you, materials management is going to circle back and say, well, they're not an approved vendor on this GPO, so you'll have to go back to looking again. All right, hospital readmission reduction programs. Now, this is something I think we as respiratory therapists need to really get involved with. We need to say, here is what we need to do to move the patient through the continuum of care. So we want to have this where we sit at the bedside and we say, well, how can I make sure that this patient doesn't get readmitted? And then we'll talk about what role we can have. Or hospital acquired condition. Now, we talked about that and have been dealing with that for a while, hospital acquired infections and that. So we need to make sure that we're doing things that limit that while the patient's there at the hospital to make sure that they don't get something else. How many of you have had patients that you've had on mechanical ventilation and they're in ICU and they're on a ventilator again and they're there for 2 or 3 days and then they're cleaning the patient to that and you roll them over and now you're starting to see some wounds show up. Or they don't even have to be in ICU, they can be in a ward bed. You start to see on their heels, their elbows, their shoulders, and that. Now, several hospitals, and you're probably part of it, where they have a program every 2 hours they rotate the patient. Or you put them on an air bed, you put them on air mattresses so they don't end up with wounds. So that's part of that program. And we're active parts of that. We, respiratory therapy, are active parts in that because we're going to go in there when the nurse says, hey, I want to roll my patient over on their left side. And again, they're on a ventilator. We're going to be there helping them, making sure they do that. So again, we're part of that. We take an active role in those things. It's absolutely okay. ET holders, again, you guys see this all the time. You can have that where it pushes in the face. And we want to make sure that we don't have that. All right, readmissions within 30 days of original discharge. Now, we talked a little bit about that, whether the patient returns to your hospital or across town, we're going to get a penalty. The original hospital of discharge receives the penalty. We're the ones that receive that. We're the ones that, hey, how'd it go? We discharged them and now they go across town or they come back into your ER. And you know those patients. You know them by name. Oh, Miss Smith, I haven't seen you in a week. I'm glad you're here. Yeah, you know them by name. And what's really kind of crazy is when the patient knows you. Oh, Steve, I haven't seen you in a couple weeks. I missed you. So I'm back. So it's like, oh my gosh. Yeah, I love you, but I don't want to see you. So again, up to 3% of the total revenue received from CMS. That's the penalty. Think about this. How many of you are directors in pulmonary care, respiratory therapy? So you say, okay, I'm going to take and I'm going to write out my budget for next year. Oh, I need 10 new ventilators. So you're writing it down. Okay, I'm going to replace my MA1s. So how much is a new ventilator? Well, $35,000, depending on what you get. So you say, well, okay, let's just make it simple. $30,000. Well, I need 10 of them. That's $300,000. So you're right. Here's my budget. So I go to who I answer to, whether it's the COO or whatever. But if you're doing the budget, you're probably going to go sit in the carpeted side of the building and visit with a CFO. And he says, well, Steve, what do you need? Well, I need new ventilators. Well, how much are they? Well, they're $30,000 a piece. I need 10 of them. Steve, well, that's $300,000. I know. I got a good deal. Yeah, well, I just bought $1.5 million MRI machine for radiology. I don't have the money for you for getting new ventilators. What? But I need new ventilators. They're, 15, 20 years old. I need to upgrade. I don't have the money for it. Now, again, we in pulmonary care have the ability to circle back and say, all right, if I can minimize my patient's readmissions and chart this and say, well, my readmissions now are down. Again, case management will know that number immediately. All you got to do is go into case management and say, what's the readmission for my COPD patient? They'll tell you what the percentage is. Remember, the national average is 22%. So if you're above, let's say you're at 25%, and you're like, okay, I need $300,000 to buy new ventilators, and you work really hard, and in 6 months you go back to case management and say, well, what's my readmission? Well, now you're at 21%. Oh, so that means, so now you get the numbers. So now you say, well, how many patients was that? Well, that was 10 patients. Oh, 10 patients at, remember, 16,000? That's $160,000. I've already paid for half of my new ventilators. So it won't take you long to say, I'm really actively participating in this. So I can actively fund my own capital equipment by not having readmissions. Does that make sense? I mean, it's just an opportunity for us to sit there and say, yeah, we're really good at this. And again, it may take you, a while to get all that, a year, but then the next year when you're doing your capital budget, now you've got, well, here I am paying for my new capital request through decrease in readmissions for those. And again, I assure you, when you sit with your CFO, he's going to say, man, that was great. Thanks for doing that. I appreciate that. So you'll get it from the carpeted side of the building, and then of course you'll get it from the patient too. Again, here it is. The national average for COPD readmissions, 22%. So if you're in there, 22% of the patients that you see that have COPD are going to be readmitted. Let's see where we're at here. Next slide. All right. Now here, focusing on this. What is it we, respiratory therapy, can do? The smartest kids in the building. I say it all the time. So what can respiratory therapy do to limit the number of COPD patients being readmitted? Educate the patient. Mr. and Ms. Smith, here's what I need you to do. When you go home, I need you to do XYZ, whatever it is. I need you to do your OPEP, VPEP, your PAP therapy. I need you to do your neb treatments. I need you to do big, deep breaths. Cough, spit. Don't spit on the therapist. Therapist's good. But I need you to do that and do it on a timeline that will keep you out of my building. I love you, but I don't want to see you for at least 31 days. So again, I'm educating at the bedside. When that patient's getting discharged, I'm educating that patient. Again, the pharmacologic impact. Neb treatments. Mr. and Ms. Smith, have you been doing your neb treatments? Well, I just know, yeah, I do it a couple times a day. You're supposed to be doing it, every 6 or 8 hours. I really need you to do this. And we're educating at the bedside before you discharge them home. Are you using your metered dose inhalers? Well, yeah, I am. Not your rescue inhaler for asthma before you show up. I need you to do this as maintenance. I need to do this. Now, here, the next one here, now own this. Communication with all care providers. You may have a great relationship with your pulmonologist, and you may say, gee, Mr. and Ms. Smith could benefit from this therapy. Oh, that's a great idea. And they start writing that discharge planning. How many of you have the ability to sit at the table at the discharge planning meetings. Do you do that? That was a new thing that I got involved with many years ago, thinking, well, if we were at the table during that discharge planning meeting, then they would get our input to say, well, the patient needs this, the patient needs that. Oh, that's a great idea. Okay, let's do that. And they'll write it out. And again, they get our input, and we need to do that. We need to absolutely say, here's what I need the patient to do, discharge. Or smoking cessation. A lot of these patients, COPD patients, they don't smoke while they're in the hospital, but as soon as they get home, yeah, they're going to go back to that. If you have a smoking cessation program in the hospital, that's great. And encourage that. Have that therapist go in there and say, gee, Mr. and Ms. Smith, here's the smoking cessation program that we need you to be involved with. It's for your total wellness. How about this? Many, many years ago, when I got married, my wife and I, on our honeymoon, went to Colorado. And we took the tramway up to Pikes Peak. That's, 14,000 feet up. And it was beautiful. I mean, it was absolutely beautiful up there. And we get off the tram, we're going into the shop where they have everything. And there was a couple of guys sitting outside at 14,000 feet smoking. So, oh my gosh, that was unbelievable. I was like 14,000 feet, I'm barely breathing, and these guys are out there smoking. Or again, when I worked at UTMB, we would transition, we get patients, we would decannulate them, and then they would come to outpatient and like that. And I saw one guy out there smoking through his hole in his neck. I'm thinking, what are you doing? But he's smoking through there where we decannulate him. So there you go, come get some of this. Or how about this? How many of you have outpatient pulmonary rehab? Tie them into this. Tell them, Mr. and Ms. Patient, you need to get into outpatient pulmonary rehab. Now, circle back with your pulmonologist, have them write those orders. So then, if they have to go and get approved through their insurance carrier, you're way ahead. Then now you can have case management make that call to get them into outpatient pulmonary rehab. And again, they come in several times a week, they go through the exercise, they learn how to use their tools, whether it's breathing, whatever it is we're doing to strengthen them. So outpatient pulmonary rehab, or they show up in the ER, instead of admitting them straight to a ward bed, transfer them to a rehab hospital, to the rehab unit in your hospital. How many of you have that at your hospital now? Have a rehab unit in your hospital. So instead of taking them to a ward bed on the third floor, transfer them to the rehab side and put them up there on the sixth floor, whatever it is. But we need to actively be involved with that. Again, the nurses are really busy taking care of all this other stuff. Well, for us in pulmonary care, we can help with that. And we can go back again, circle back to the ER physician, say, well, maybe Mr. and Ms. Smith would benefit from inpatient pulmonary rehab. So again, if you don't have it in your building, across town, there's a rehab hospital, send them to it. Say, gee, Mr. and Ms. Smith, here's an opportunity. And again, you can do, 23-hour obs, then transfer them out. Does it make sense? Yeah. So how do we educate that patient? Again, we in pulmonary care, I think, smartest kids in the building, you know exactly what's going on with that patient. You look at their radiographics, you look at their films, you place your healing hands on them, your oscillatory findings tell you left, right, left, right, left, right. So again, you're going to visit back with that patient. And again, there's a charge that you can generate. It's not like you're not going to get paid to do that. There's patient education that you're going to get paid to do that. So there's a code for that. And again, if you don't know what it is, go to the ARC and you can look at that. So again, you'll know what that is. And then you can do the education. And then can you charge for? Yes, there are outpatient pulmonary rehab programs that you can charge for. That's why they exist. They have the ability. And again, CMS has looked at that, and years ago they decreased the funding for that. Now they're increasing the funding for outpatient pulmonary rehab. So we have the ability to fund that through that. Now it's not going to be funded, and that money's not going to go to respiratory therapy. It's going to go to pulmonary rehab. But again, you're keeping them out of the building. You're minimizing your costs, and those are huge things. So yeah, there's financials that we get paid for education, and then the hospital is going to get paid for having pulmonary rehab. All good, all good. All right. How many of you have heard about this? The SOAR Act, Supplemental Oxygen Access Reform Act, and it's already been introduced to the House of Representatives. Went to government late in the fall, and then we had a lot of activity in the fall. We just elected a president, went through the presidential stuff. Then in January, trying to move through the new year, the ARC is going to really push hard, but it's going to be reintroduced back in. And I think this year, because we are really in a cost saving mode from a governmental standpoint, we've been in it for a while from the AARC, but now here it is. Now, what does that mean? How's that going to benefit? Okay, the SOAR Act, access to oxygen reform. Okay, so we send patients home and they go home on oxygen. And this is how it is right now. And those of you who work in the home care arena, help me with this. So the patient goes home, they're on, 2 liters. So we have a concentrator, we send it home. The home care company says, oh, great. We're going to send Mr. Smith home on oxygen. That's awesome. So they put it in the back of the truck. And then, so they're going to need a neb driver. Oh, they put that in the back of the truck. So then the driver gets to the patient's house, unloads all that in the patient's living room, and says, okay, Mr. Smith, we'll see you. And out the door he goes. So now I've got an oxygen concentrator and that. Now the nurse may follow up and say, okay, make sure it's on 2 liters and that, but there's really no education that goes into that. Or pulmonary rehab at home, or any of those other things that we do. Well, the SOAR Act will now pay us to be in the patient's house. So we're going to get reimbursed for going there, which we haven't been. Our participation has been paid for. That's why there aren't respiratory therapists to go in there. So now, whether the patient goes home on oxygen, CPAP, neb treatment, something like that, we, respiratory therapists, are going to be there at the bedside guiding that patient along. And then again, we're going to have the ability to do that. I think that's huge, just a huge thing, a huge thing. So here it again, more than 1.5 million people across the U.S. face unparalleled challenges accessing oxygen that their lives depend on. I just can't imagine what it would be like to live where every time you get up, just to go across the room, you become hypoxic. Your SAT drops to 85. That would be, I just can't imagine what that's like. I mean, I just can't imagine. We want to have access to that. And again, the ARC is pushing this. These roadblocks are largely caused by inadequate Medicare reimbursement to the system. We just talked about that. Respiratory therapists are not funded to go into the patient's house. We're not. Now we can do that. And then lack of access, and here it is, drive it, access to the skills respiratory therapists can provide to oxygen-dependent patients. Who knows that better than us? Who understands that? Who gets that? Again, here's the stuff that we get all the time when we understand that. Do you remember the oxygen hemoglobin dissociation curve? Yeah. We had to know that. It was on the boards. We had to know what that is. We understand what that is. So again, as we're educating the patient, we're moving the patient across the kid. I know what stresses cause that right shift in the dissociation curve. I understand that. Now I'm going to communicate that with my other care providers and, more importantly, to my patient. Say, Mr. Miss Smith, this is what you need to do. Make sure that your cannula is in your nose and not on your chin, or you can't get oxygen through your ears. You need to have the cannula positioned where it works. And again, we're going to provide that education. We're the ones that do that. All right, continuing to recognize respiratory therapy and their crucial work in improving healthy patient outcomes is another key component of this legislation. So again, tag your it. Here it is, continuing to recognize respiratory therapists and their crucial work in improving healthy patient outcomes. I want my patient to only have the very best. I don't need to see them in 2 weeks. You don't need to see them. So again, this is part of that. So how does that work? We're going to get funded for that. And again, the ARC is really pushing hard into this, and they've gone into detail, meeting with those people that vote on this. Now, I have sent emails to my congressman many times talking about the SOAR Act, and I've got replies back from them saying, "Thank you, Steve. We really appreciate it. Thank you, Steve. We really appreciate it." So again, if you have access to your congressman, send them this information. Say, "I need you to vote for this." Advocating for improved patient access to respiratory care outside the acute care setting would allow supplemental oxygen patients to lead fuller, more robust lives without financial hardship worries. And that was Carl Hickson. That was his statement. I think that sums it up. I mean, that says it right there. I need to have an active role in that patient, moving them through the continuum of care. And the continuum of care is not just in the hospital, but when the patient goes home. Here again, we look forward to continue to work with our coalition partners, the House and the Senate, to turn these necessary policy changes into law. Again, the ARC is really doing this, but you, me, TAG, we're it. We need to have an active role in that as well. So take the time and write your congressmen, write your senators, and say, here's what we need to have happen. This will be a benefit for us and the patient. All right, so here's a whole host of information. Comprehensive, affordable discharge bundles. Now think about this. Build this program if you don't have it, or if you already have it, invest respiratory therapy, your time into this. So 24-hour calls, we need to have access to that. So if the patient at home, 24 hours, 2 o'clock in the morning is having an event, the home care company can call you and me. We'll get in our car and go out there and see them. And then discharge planning. They do this, but now this will allow respiratory therapy to have a part of this. In 7 to 10 days, we're going to have a follow-up call. We're going to call them. We respiratory therapists, we're going to call Mr. and Ms. Smith and say, how you doing? What is it we're doing? And then a referral to pulmonary rehab. We talk about this in the hospital when they're at home. Mr. and Ms. Smith, I need you to go, and here's the referral for pulmonary rehab. You need to go home, get stronger, feel better about that. Do that 6-minute walk. Oh, you do need oxygen. All right, here it is. Here's your oxygen. I need you to keep working on that. Get better. Home visits. I'm going to knock on the door, say, hi, Mr. Smith. How are you? Well, have you been doing your neb treatments? Yes, I've been doing them, Steve. Just like you told me to do 3 times a day. My oxygen. Okay, great. Or if he says, I'll be doing this, how is it I can help? I want to be a helper. Smoking cessation. We drilled into this. Mr. Smith, stop smoking. It's not going to work. And then device instruction. How am I using my oxygen concentrator? How am I using my neb treatments? How am I using my OPEP devices? How am I using my PAP device? All those things, Mr. and Ms. Smith, I need you to do this. And then patient family engagement in all decisions, and not just education. Again, if you're talking to a loved one, and there may be some lady, they were like, I don't even know what you're talking about, but I want them to be involved. So again, as you're explaining this to Mr. Smith, look at Ms. Smith, the wife, and say, do you have any questions? How can I help? Or kids. My wife, her 96-year-old dad lives with us. We moved him in a few years ago, and we do a lot of things for him. Now he's pretty good, but 96. Well, again, when we go to doctor's visits, we listen to what the physician says so we can reinforce that with dad. We've had to have home care visits where they're, Dad, here's what we're going to do for your wound care. Here's what we're going to do for nutrition. But again, we were part of that discussion. So when we visit with dad later, We have that. And then multidisciplinary COPD clinics. A lot of times it's not just us in respiratory therapy that needs to be involved with that. Think about these multidisciplinary COPD clinics. Okay, what does that mean for multi? Okay, so I'm gonna have my physician, nursing services. Well, do you have pharmacists involved? What about nutrition? If you look at these patients that come in, how stressed are they nutritionally? So they're blowing through every bit of calories they've got. So you're like, oh man, I need to put them on a 2,000 calorie a day regiment dietary. 2,000 calories? No, see, there's no way. Yeah, but they're blowing through all their calories. That it's like, okay, we've got this. Let's do this. Consult them from a nutritional standpoint. All right, looking to address comorbidities. Okay, they got wound care. We get that. Empower pharmacists and we, smartest kids in the building, respiratory therapists. Again, we need to do that. We are the coolest kids in town. All right, value-based care. What does that mean? Accountable care. A person-centered care takes team responsibility, improving the quality of care. I'm improving my patient's quality of life. I'm not kidding you. It doesn't take any imagination to throw a nib on somebody, give them some. I'm improving their quality of life. Care coordination, the organization of an individual's care across multiple healthcare providers. We've talked about that. Integrated care, an approach to coordinate healthcare services to better address the individual's physical, mental, behavioral, and social needs. Think about that. So, value based care, designed care so that it focuses on quality, provider performance, and the patient, focuses on the patient. Think about what the patient needs. All right, value-based care, value-based, and we keep going over this. It's a term Medicare doctors and other healthcare professionals sometimes use to describe healthcare that's designed to focus on the quality of care, provider performance, and the patient experience. Mr. and Ms. Patient, how'd it go? How is this? I need you to do this. Mr. Physician, I need you to communicate to the patient. Again, we respiratory therapists take an active role in that. The value and value-based care refers to what that individual values the most. Mr. Smith, what's important to you? Well, I haven't been to church in a month and I'd really like to go. Okay, we can maybe get some portable oxygen for you so you can go to church. That's important. So not only their biophysical needs, but their psychosocial needs as well. And we need to think about that. So again, what is it? Manage patients' overall health, considering individual personal health goals. For example, doctors might coordinate individuals' blood work, so they need to go one time to the clinic and not 3 times a week. The approach to care can also help people avoid emergency departments and keep them out of the hospital. I love my patients. You do too, but I don't want to see them back in the building. I just don't, not for 31 days. All right, how does value care help treat the patient as a whole person? Now, again, I just said this. Value based care puts greater emphasis on integrated care, physical, mental, behavioral, social needs. Providers treat an individual as a whole person rather than focusing on a specific health issue or disease. Bold letters, meeting the patient's biophysical and, highlight this, psychosocial needs. Get in their head a little bit, say, how is it I can help, Mr. Ms. Smith? How's it going? What can I do to make you feel better about yourself? Not just, okay, here's a band aid, but how can I help with that? Does that make sense? All right. Value based care, treat the patient as a whole person. Healthcare teams spend time with individuals receiving values based care to fully understand what are the obstacles. And here's something that we sometimes don't know because we don't have an intimacy with the patient once they get discharged. Well, again, the SOAR Act will allow that. What are the potential obstacles or barriers to their care? Well, I don't have a car. I can't go to outpatient rehab because I don't have a way to get there. Well, some communities have where they have transportation services. Maybe there's some transportation service that you can team up with EMS. They may have that, where they have the ability to do that, where they can team up. Your hospital may have that. Again, I can have my hospital come and pick you up in the hospital van and bring you. But again, if we don't know, because we don't ask those questions, I'm asking you, ask those questions. What is it that you need, sir? What is it that you need, ma'am? How can I help you? What are those barriers? What are the barriers to that? How does value based care treat the patient as a whole person? Non medical factors could have a direct impact on the patient's well being. We just talked about this: transportation, healthy food, relationships with family, general living conditions. How many of you ever made a house call? How many of you ever gone to somebody's house? Sometimes they're really nice places. You're like, okay. Other times, not so nice. You go into their home and you're like, oh gosh, okay, maybe I can help with this. Maybe I can get a referral to something else. But sometimes people don't live in nice places. And it's like, can that be a potential hazard? Personal health goals. Healthcare teams can develop a treatment plan that matches with what the patient hopes to achieve from their healthcare. So again, we're going to ask questions. We're going to say, Mr. and Ms. Patient, what is it like? What is it you want to do? How can I help you? Ask the patient, ask them. They'll tell you. How does value based care address health equity? Putting focus and having measurable impact on the health outcomes of every person, even those in underserved populations. How many of you have patients that are in underserved populations for whatever that is? And that underserved population can be they don't have the financial resources to access good care. That would be an underserved population. And we see that all the time. The financial implications are huge. Encouraging healthcare providers to screen for social needs and work with individuals to develop personalized treatment plans that can address each person's unique needs. I'm not going to know that unless I ask them. And again, get with case management, partner with them, partner with your other care providers, walk through the process with them. Requiring healthcare providers to monitor and track outcomes across populations to address for disparities and intervene as necessary to help close gaps in access to care. I mean, it just is unbelievable. Sometimes patients like, I just can't get to the hospital. I just can't get this care. I can't get these things for whatever that reason is. And again, the SOAR Act is going to help. But again, we're going to have to invest some time, some upfront time, ask some questions. Say, case managers, do we have access to this? Can we provide that to the patient? And I assure you that case manager has got this down. They're going to know exactly what that is. And they're going to say, yeah, we can help with that. We can do those things. And again, I'm not going to know unless I ask. And take the time to hold your patient's hand, visit with them on an eye level, eye to eye, and say, how is it I can help? How is it I can help? I think this is huge. I went to a conference a couple of years ago, and I heard, and this the saying, I was like, what is this? What is this? Teresa is an instructor at one of the community colleges up in Fort Worth. And she said this: to be valued, you must first bring value. Is that not a true statement? To be valued, you must first bring value. If you're just a neb jockey or an O2 boy and girl, what's the value in that? You're just checking it off the list. And we're way smarter than that. Again, I say this all the time, whether I'm doing a conference before you or I've done them in, Utah or Vermont, where we're the smartest kids in the building. We, respiratory therapists. And people just don't know how smart we are. As you bring value, then they're going to say, oh, yeah, they're on my team. I need a respiratory therapist on my team. I need to have them do that. Now, many of us, when we're going through the patient that's in the ICU and they're getting off the ventilator and like that, yeah, they'll probably ask, okay, we're doing grand rounds or rounding. They're seeking our input. That's great. On the ward beds, not so much. Just not so much. Then I'm trying to find my physician to say, Mr. Smith isn't doing well. Dr. Jones, can we do this? I'm waiting for my physician to round. And it's like, yikes, man, sometimes I miss them. And so I'm writing notes and then I don't get a response. I'm like, yikes. So again, we need to be part of that. And again, we can do that, focusing on that discharge planning committee. Once we get involved with that, I assure you that those care providers that we surround ourselves with will say, there's respiratory therapy. There's the value that they bring. And they'll solicit and they'll come get us instead of running out in the hallway saying, hey, respiratory, I need this. Again, to be valued, you must first bring value. So every day you show up, your charge is to do what? To bring value. I'm going to bring value. I'm going to move my patient through the continuum, do the very best job I can to take care of that patient. Because I assure you, one day, your loved one is going to be in that bed. And you're going to hope somebody like you is taking care of them that cares about the patient. Or ultimately, one day it's going to be your head in the bed. And you're hoping that when that happens, that whoever's taking care of you has the same mentality to do the very best for you that you do for your patients right now. Does that make sense? All right, here we go. A couple slides left. And this is so true. This is just so true. Respiratory therapists are the Batman and Batgirl of healthcare. We get the signal, we show up with our gadgets, we save the day, disappear, and no one knows our name. Is that true? How many times, how many times have you been working, whether it's in ICU or a ward bed, wherever it is, and the nurse comes out of the patient room and they says, hey, respiratory. And you show up and they're saying, let's do a ward bed. My patient sat is, 85 and they need to be 91 and they're calling you and you go running in there and, hypoxemia kills. So I'm going to fix that hypoxemia. So one, I make sure that their pulse oximeter is on correctly. But again, the patient's cannula is up on their forehead. Oh, I got it. Yeah, I got you. So we move it down, we put it into their nose, and within 2 minutes, now their SAT is up. Or the patient has some febrile process going on, so their fever goes up. Remember the oxyhemoglobin dissociation curve, shift to the right, hydrogen ions, temperature goes up. I'm going to fix hypoxemia. I'm going to take care of that. So the order is the patient needs 2 liters of nasal cannula. Their SAT is 85 on a 2-liter nasal cannula. It's hooked up. I'm fixing that. Hypoxemia kills. I'm taking that cannula. I'm putting it up to 5 liters a minute. I'm going to stand there while the patient's slow breathing and watch their SAT come up. Now I'm going to find out, why is that patient's SAT dropping? Oh, well, they have febrile. Okay, do we need to give them an antipyretic? Whatever that is, I'm going to fix that. I'm going to address that. Oh, thanks, Steve. But I'm going to fix that hypoxemia because hypoxemia kills. Our goal is to fix that. And again, we are the smartest kids. We show up with all of our stuff, fix the problem, then disappear. And they're like, who was that? Yeah, that's who that was. That was I'm the Batman or Batgirl. And here it is. Man, I did it. I got right on time. Let me just say this. Let me thank you again for everything you do every day, taking care of those that cannot take care of themselves. It is a privilege. Again, I've been a respiratory therapist now for 36 years. It is an absolute privilege to take care of those that can't take care of themselves. And I appreciate each and every one of you and everything you do every single day to take care of those that can't take care of themselves. And that's the end of my presentation.